Hello, everyone. I'm Himanshu, consultant in reproductive medicine, and welcome to our YouTube channel for teaching in basics of obs and gynae. Today, we are going to talk about disorders of sex development. So, we'll talk about meiosis, which is maturation of germ cells. So, germ cells are haploid, so they have 22 autosomes and one sex chromosome, which is either X or Y. Other cells in the body are diploid, so they have 22 pairs of autosomes and a pair of sex chromosome, which is either XX or an XY. And as you all know, XX is a female genotype and XY is a male genotype. Meiosis begins with rearrangement of the genetic material within the nuclei of the germ cells for both male and female, and reduction from diploid to haploid occurs during fetal life in the female. However, in male, it is delayed until puberty. So, as you can see, so the primary oogonium undergoes mitosis, forms a primary oocyte, and then at puberty, the egg is arrested in metaphase 2, and the first meiotic division is complete at the time of ovulation, and the second meiotic division is complete at the time of fertilization. Whereas in male, spermatogonium undergoes mitosis, then becomes primary spermatocyte, then first polar body is released after the first meiotic division, and then second meiotic division happens and spermatids are formed. So clinical syndrome, so X chromosome favors development of female characteristics, although full development is possible only if there are two such chromosomes. Any alteration in this number leads to abnormalities. Development of the testis is entirely dependent on the presence of Y chromosome. So on Y chromosome, there is a gene which is called SRY gene that has got sex determining region of Y gene. And because of that, the male phenotype and testis develop. The testis, in addition to forming testosterone, which aids in the development of male characteristics, also produces a substance called MIS or MIF, Mullerian inhibitory factor. In the absence of a testis, the whole Mullerian tract will develop, but curiously, this does not depend on the presence of the ovaries. In any case of genetic defects, you need to complete family history properly and perform a chromosomal analysis in the form of karyotype. Turner syndrome, which is sex chromosome deletion X. So it presents with amenorrhea. The intelligence level is not affected. There could be webbing of neck, coarctation of aorta, absent secondary sex characters, infantile figure of female phenotype, small stature, poor hip development, streak gonads, uterus and fallopian tubes are infantile. So for proper maintenance of the ovarian reserve, both X chromosomes are needed. So when in Turner syndrome, one X is missing, these reserve of primary oocytes is depleted even before the female fetus is born, and only the supporting tissue is left behind. So the ovaries will appear like a streak of sclerotic tissue, and that's why they are called or referred to as streak ovaries. The commonest pattern is 45XO, but not always all the features will be present. Sometimes there is a partial deletion or mosaicism, in which case a milder version of Turner syndrome can be seen. And in these cases, ovaries can develop and menstruation can occur. And depending on the degree of mosaicism, they will be menstruating up to a certain age. So I have patients who became amenorrheic after 20 years of age or at 24 or 34, and when we did the karyotype, because this is called as premature menopause, we found out that they were mosaic for Turner syndrome. Consider the diagnosis early in girls with short stature, and they require HRT to encourage skeletal and secondary sexual characters development. In younger women, combined contraceptive pill is often socially acceptable maintenance therapy that results in a menstrual cycle. Klinefelter syndrome. So this is sex chromosome acquisition of X chromosome. Y chromosome with an increase in number of X chromosome. So the commonest abnormality is 47XXY. And because of the Y chromosome, phenotype is male. Clinical features vary, but majority have hypogonadism and infertility. Facial hair is scanty and pubic hair distribution is female. Gynecomastia can also be present. Mild developmental problems and learning disabilities can occur. Vast majority of these patients have normal intelligence. An association between mental impairment and the number of X chromosomes, meaning higher the number of X chromosomes, there will be a greater degree of mental impairment. What it means is if someone has 46XXY genotype, that person's mental impairment will be better than patient with 47XXXY or XXXY. Super female, so sex chromosomes acquisition X, and sometimes at both stages of meiosis. So the patient possesses an extra X chromosome, but there is no Y chromosome, and that's why the phenotype is female. Pattern could be XXX or XXXX or even XXXXX. Physically normal females, and usually some mental impairment is seen, and the degree of it increases with each extra X chromosome, and diagnosis is made by chromosomal analysis. Complete androgen insensitivity syndrome, so previously known as testicular feminization and mistaken for chromosomal abnormality. Chromosomal pattern is 46XY. However, there is insensitivity of the androgen receptors to respond to the androgenic stimulation. As a Y chromosome is present, testes form normally, producing anti-Mullerian hormone and testosterone, and because of the anti-Mullerian hormone, there is a regression of Mullerian duct system, therefore female reproductive organs don't form. But due to the androgen insensitivity, lower genital tract fails to virilize and a short vagina is formed. Patient is phenotypically female, and diagnosis is made in early adult life when patient presents with amenorrhea. So if you remember in embryology that the embryo default setting is female, and when the Y chromosome is present, because of the sex determining region of Y, the male phenotype will develop. However, that requires testosterone, and because in these cases there is androgen insensitivity, so the receptors are not responding to the testosterone secreted, the male external genitalia fail to develop. Because of the anti-Mullerian hormone, the Mullerian duct has regressed, so the female internal organs don't develop either, and the vagina is short. The phenotype is female, normal or large breasts with small nipples, absent or scanty pubic and axillary hair, female extragenitalia with a blind vagina, absent or rudimentary internal genitalia, undescended testes, testes do secrete estrogen and androgens, and probably the Leydig cells produced feminizing hormones. Usually they inherit from mother in an X-linked pattern, but new mutations are common too. Most carriers are unaffected, but some may show scanty pubic and axillary hair and have delayed menarche. Until full growth is achieved, no therapy should be attempted. After puberty and epiphyseal fusion, gonads need to be removed surgically as preventive measures to avoid cancer progression, because the undescended testis can progress into a cancer of the testis, and that's why they need to be removed. These patients will need HRT after removal of the gonads. Social, psychological, and sexual problems because of this, which can be helped with counseling. Karyotyping and counseling is needed, and partial androgen insensitivity syndrome can occur presenting with ambiguous genitalia. Now, congenital adrenal hyperplasia. So in this condition, there is abnormal cortisol production affecting both male as well as female infants. The commonest enzyme deficiency is 21 hydroxylase. And because of that, the adrenals also produce mineralocorticoids and steroid hormones, and deficiency in one pathway leads to excess production in other pathways. And severity of the enzyme deficiency can vary, leading to different clinical presentations. It should be detected and treated at birth because there is a low cortisol secretion that leads to pituitary producing very high amount of ACTH, and that leads to adrenal hypertrophy. As pathway to cortisol is blocked, alternative pathways to androgen formation is taken, and the fetus and the neonate show signs of virilization. If aldosterone production is affected, the salt losing effect can be potentially life threatening if the condition is not detected promptly. And that's the reason that sooner this condition is detected and treated, the outcome would be better. In female infants, there is virilized genitalia, and the chromosomal analysis will reveal a 46XX karyotype. Addisonian crisis may develop at any time and could be fatal, and that's why early detection is very important. Diagnosis must be recognized soon and corticosteroid replacement therapy given immediately. This will reverse the changes in endocrine organs, reducing ACTH level and ultimately reduction in adrenal hypertrophy. Further virilization will be prevented, but surgery may be required for female infants with virilized genitalia. Abnormal genitalia should alert the attendant at birth, and help should be sought from a pediatrician. Milder forms of congenital adrenal hyperplasia can present later in childhood and adolescence with precocious puberty and oligomenorrhea. CAH is an autosomal recessive condition, and prenatal diagnosis is possible. So as you can see, the CYP21A2 gene mutation causes 21A alpha hydroxylase deficiency, and because of that, adrenal glands can't make enough cortisol and aldosterone. And because there is no feedback to the pituitary, pituitary produces excess ACTH to stimulate the adrenal glands, and that's why there is a greater risk of adrenal hypertrophy as well as tumors. Now, abnormalities of ovary and tube: incomplete development of Mullerian ducts, imperfect development of the gonads, imperfect development of the cloacal region, and sex chromosome abnormalities. So in the ovary, absence of one ovary may occur in an otherwise normal woman. Before operating, that's why it is very, very important that you should see both the ovaries first, make an assessment, and then start operating. Otherwise, if by mistake, if you remove the only ovary, that will suddenly push the woman into menopause and cause further complications, especially in women with childbearing age. Ovary will appear as a streak in ovarian dysgenesis, and it may contain vestiges of rete, occasional germ cell type cells, but there are no follicles. And these remaining vestiges can develop tumors such as gonadoblastoma and dysgerminoma, and that's why they should always be removed. Abnormalities of fallopian tubes. So absence of tubes is very rare, but sometimes they can be imperfectly developed, and that can directly contribute to either subfertility or infertility if the abnormality is bilateral. Abnormalities of uterus. So either there is an absent uterus or improperly developed uterus or rudimentary uterus. The uterus consists of two nodules connected by membrane, and other structures are normal. If the cavity exits in a nodule, it will lead to cryptomenorrhea, that is, concealed bleeding, and dysmenorrhea may arise because of the collection of blood, and the retrograde flow through the fallopian tube into the pelvis can lead to pelvic endometriosis, and it can be associated with atresia of vagina, which is Mayer-Rokitansky-Kuster-Hauser syndrome, MRKH. Sometimes there could be double uterus, or it's called uterus didelphys. So sometimes the uterus is double, the cervix is double, and it can also be associated with a double vagina because of a vertical septum. Bicornuate uterus, where uterine horns are two and not fused. Uterus with an accessory horn, sometimes because of the incomplete reabsorption of the membrane, there is an arcuate uterus, or there is a complete failure of the membrane to be reabsorbed, which leads to septate uterus, or sometimes only one horn develops that leads to uterus unicornis. That means there is only one horn. So as you can see, a normal uterine cavity is triangular because it grows with two tubes and the septum will get reabsorbed, so the resulting cavity will be a bit triangular. But sometimes these two tubes will develop completely separately, and that leads to uterine didelphys. So the interesting fact about this nomenclature is, if you remember, there is a city in Greece called Delphi, and Delphi in Greek language means navel, and that's why uterus was named Delphus, or that's why there are two uteri called didelphys. And for the same reason, dolphins are named, because they were the fish with a uterus. Arcuate uterus is when this reabsorption is incomplete, so you can see there's a dip in the fundal area. Unicornuate uterus means only one horn develops. Bicornuate means the reabsorption is not complete, so the two horns develop separately, and when the absorption is not complete, you can see the whole septum, which can actually sometimes extend into the vagina as well. Abnormalities of vagina. Gynaetrisia may be due to complete absence of vagina or incomplete development. As you remember, the upper two-thirds of the vagina develops from the Mullerian duct, and the lower one-third develops from the ectoderm. When the uterus is absent with absent vagina, it is called MRKH syndrome, Mayer-Rokitansky-Kuster-Hauser syndrome. Sometimes the vagina is associated with septum, and they could be both, as we saw. It could be a vertical septum leading to two vaginas, or a transverse septum, which will practically work like imperforate hymen. Depending upon the extent of the abnormality, pregnancy and delivery is possible. It can occur alone, but usually associated with abnormalities of genital and renal tract. So if you remember, the urogenital system develops together in the embryonic life, and that's why abnormality in one system is usually associated with abnormality in the other system. And that's why when we see a patient with Mullerian anomalies, we always perform an ultrasound scan of kidneys, or sometimes a CT or an MRI is needed to make sure that the kidneys are formed properly. And sometimes you will need a laparoscopy to get the full idea about the development. Abnormalities of vulva. Absence or duplication is extremely rare. Wide variation in size of the labia. Ectopia vesicae, where the bladder is opening at the anterior aspect, which is an extreme defect, and it is because of the failure of development of symphysis pubis, mons, lower abdominal wall, and anterior wall of the bladder. So you can see the whole cloacal region is exposed. So when you see the fetus, you will see that there is no mons, there is no symphysis pubis, the anterior wall of bladder is missing, and just the posterior wall of the bladder with ureteric opening and trigone is exposed. And that's why a surgical correction is needed. Thank you very much.